Hey, Susan, thanks for having me. Emma, thanks for being out there as well. Hello, everybody. It looks like a good lunchtime crowd today. So hopefully we can help advance some knowledge on NT-proBNP and cardiac assays with you today. I'm really happy to be here. I just had a knee replacement surgery just about a month ago and done a couple of Zoom meetings since then. And hopefully in 2 weeks, I'll be back on the road and teaching and practicing and doing all the fun things that I'm used to doing. So for today, we're going to again talk about cardiac NT-proBNP, an assay that the fortunate thing is you can now do in your clinic as well as sending them out. But we're going to focus today on some of the applications for doing it in your own house, which is kind of cool. My title slide here, if you look at that poor heart right over here, he doesn't look so healthy, does he? And I want to go way back to 1989 for you guys that are out there that remember music back then, the Swedish pop group Roxette. Remember that song, Listen to Your Heart,
Hey
when he cries
Gary,
out to you. Yep,
I'm sorry to interrupt. Somebody's mentioning they're saying that you're echoing.
I'm
It's
echoing. Okay.
you're not echoing to me, but if anybody else is
Yeah.
having the same problem, if you could just let me know in the Q&A box.
Okay, I can
Um,
try to, let me see if I just turn my sound down a little bit for my microphone. Maybe that'll stop some echo.
okay.
All right, we'll try that, guys. So again, 1989 Roxette, Listen to Your Heart. And that's what we're going to talk about today is that cardiac NT-proBNP is really the heart crying out to you to hopefully identify the fact that a patient has heart disease. Susan gave you a nice introduction, guys. The most important thing for you guys to know here today is this bottom part here. That's my email. And if you have any questions on today's presentation, by all means, you're certainly more than welcome to email me about things. All right, well, let's talk a little bit about heart disease and where this NT-proBNP thing fits in. I think we can all agree that when it comes to heart disease, there's a variety of different diseases. There's valve disease, there's cardiomyopathies, there's congenital heart diseases, there is hypertension and pulmonary hypertension. There's a variety of different things that affect the heart. And obviously, with any disease, the earlier we can recognize those issues and begin management, the more likely we're going to be successful. And hopefully that translates into a patient living a better quality of life and hopefully a longer life. So, when it comes to cardiac disease specifically, again, I think we can all agree that our physical examination and many times our ancillary tests like chest x-rays, ECGs, they just don't always provide us that window of early and accurate diagnosis. In fact, there are a number of cardiac diseases that can hide from us from quite some time unless we actively, as clinicians, go out and try to see if a patient has those. So, for decades now, there's been an interest in not only veterinary medicine, but first in human medicine to develop a blood-based cardiac biomarker that could, with accuracy and precision, tell us whether a patient has heart disease, maybe tell us a little bit more about how severe that heart disease is, and maybe prognosticate how a patient will do with that disease. And since the year 2000, we've looked at numerous biomarkers, epinephrine, norepinephrine, troponins, and then we got into the natriuretic peptides, ANP, atrial natriuretic peptide, and then BNP, which is either you can call it beta 2 natriuretic peptide, or some people refer to it as brain natriuretic peptide, even though it's produced primarily in the heart. I think in veterinary medicine and to some degree in human medicine, we've settled on this BNP molecule as our assay of choice that we can, again, hopefully find patients that have heart disease, recognize things about heart disease that can help us as clinicians. So we're going to focus today on this thing called the N-terminal fragment. It's a molecule of proBNP. And let's take a look and see what that's all about. So what is beta natriuretic peptide? So what doesn't fit in this picture here, guys? These are plush toys that you can go online, Amazon. You can buy them, put them in your waiting room, put them in your examination rooms. They're pretty nice for the kids to play with. But I think let's see who doesn't fit. This is our pituitary gland over here. Adrenal gland. Of course, if you get that, you better buy two because they have two. This is our thyroid gland with the bilobed nature. And then you see, of course, the pancreas down here. Well, why is the heart here? I mean, we don't normally think of the heart as an endocrine organ, but in fact it is. I mean, certainly it does a lot from a standpoint of, pumping and moving blood through the system, but it also has endocrine function that it does as well. So it fits beautifully into this category, and you would be able to buy that plush toy if you chose to as well. So let's take a look then at this beta natriuretic peptide, this BNP. Again, it's a cardiac hormone. Why and where is it produced? We're looking at beta natriuretic peptide. It's primarily produced in the ventricular myocardium. Obviously, ANP, atrial natriuretic peptide, would be produced predominantly in the atrium if we were measuring that. But why it's produced is that when the heart is stressed or stretched, again, when you get increased diastolic volume or preload, that heart stretches, and that's one of the things that occurs prior to heart failure. Again, remember that renin, angiotensin, aldosterone system. You can't go through a whole day without saying that. Isn't that true? It's so important in everything in medicine. But again, this RAS system, when it causes increased preload by, again, sodium retention, water retention, it's going to basically stress or stretch the heart. And the heart responds to that. And that's why we call it this cry for help. The heart is going to go ahead and produce in the cardiomyocytes this 108 amino acid molecule called proBNP in response to this perceived pressure or stretch that it's undergoing. That molecule or that hormone now is released from the cardiomyocyte into the bloodstream, and as it's being released, a membrane-bound protease called corin divides it into two segments. And basically you get BNP, which is a 32 amino acid segment. That is the active hormone, and we'll see what that does in a second. And also you get it cleaved into this 76 amino acid called NT-proBNP. That's an inactive fragment of the molecule that again is broken off when it is released. Because this is in the bloodstream, it's something that we can detect. I apologize for a second. I have a lawn person here and they're about to blow their grass clippings out of my doorway. There they go. Good. So it's a blood detected biomarker. And again, if we can detect it at elevating in the bloodstream, it's going to be associated with significant cardiac disease. So what is the function of BNP? So the active molecule, BNP itself, basically promotes vasodilation. So it's going to reduce blood pressure, reduce afterload, if you will, on the heart. And it's going to also tell the kidneys to go ahead and get rid of excess sodium and water. So it's a natural, diuretic hormone that is counterbalancing that renin-angiotensin aldosterone system. So again, when the heart's diseased, our cardiac output goes down, the RAS system is kicked in. And again, as the heart senses that, it tries to protect itself. So it, again, is a physiologic response to say, hey, wait a minute, let's see if we can reduce a little bit of that pressure, reduce that afterload, get rid of some of that preload. Again, heart trying to help itself. But at the same time, it's calling out to us as physicians or clinicians, and it's saying, help me. I'm stressed. You can figure this out by looking at my blood panel, and I need help. And that is the significance of the biomarker function of this hormone. What's interesting about it is that this hormone is degraded by another enzyme in the bloodstream called neprilysin. And you may have heard of this drug. You see it on TV quite a bit called Entresto. Entresto is an ARB, valsartan, angiotensin receptor blocker combined with sacubitril, which is in fact a neprilysin antagonist. And basically it's a drug that tries to reduce the RAS system by both blocking angiotensin aldosterone and raising natural BNP levels. And there's been a little bit of work so far in veterinary medicine. In the last couple of years, there's been a couple more published papers. But again, in the last 7 or 8 years, we've had an interest in starting to see whether this type of drug that can actually enhance our body's own BNP would be helpful in patients in heart failure. So again, things are moving in a cool direction. So why is it that we measure proBNP, NT-proBNP, and not the active molecule of BNP? Well, the reason is primarily several things. The inactive segment, this NT-proBNP, has a longer half-life. It achieves a higher plasma level. and it's a much more stable molecule. So based on those three attributes, it's going to be much better and easier detected in the bloodstream. And as such, it's going to be a much more sensitive indicator for heart disease. The sensitivity will be high, meaning patients that have significant heart disease are going to have an elevation in NT-proBNP. You're not going to have a lot of false negatives, if you will. So that's the reason why we have chosen the NT-proBNP fragment, this molecule that's inactive, as the assay of choice. Now, there's two ways that you can currently, or actually three ways you can currently measurement. One would be to send a blood or plasma sample, serum or plasma, out to a reference laboratory. IDEX does a cardio test for this hormone, or we can go ahead and we can do this in our own clinics. Guys, sorry about this. Not only do you have my lawn guy here today, now I have a thunderstorm and lightning and thunder over my house. So you get all the best of all best worlds in Florida right now. So again, we can either send it out to a reference lab or we can do these in clinic. And there's a huge reason, as you'll see in a couple minutes, for you to start thinking about, if you haven't already, doing these in clinic. There's some great applications in how it can help you in the practice of cardiopulmonary medicine. Most of the time when you send it out to laboratories, it's going to be an ELISA test, an immunoassay that's done. There is a SNAP test that IDEX offers for cats. We'll show you that in a second. Or our sponsor today, Zomedica, as you see here, has a machine, the TRUFORMA machine. We'll speak about that a little bit at the end, that can assay proBNP and done in clinic, but it's done with a completely different type of immunoassay called bulk acoustic wave. And it's a really cool newer technology that allows us to do very precise, very accurate measurements in multiple hormone levels and other molecular assays, not just BNP. So you'll see the application of that in a bit. So the next logical question for you guys, now that you know what BNP is, why we've chosen NT-proBNP as the assay of choice, would be how can you use it in your practice? Dr. De Lima here, Gabriela De Lima, down in Brazil a couple of years ago, wrote a paper, and I love this quote that she put in there. Cardiac biomarkers should be considered as important as any other biomarker, such as renal or hepatic ones. I mean, think about it. Your CBC, your chemistry panel, you're able to look at bone marrow function. You're able to look at platelets. You can look at kidney function, liver function. But there's very little, if anything, on a basic blood panel that tells you about the heart. And again, this NT-proBNP is powerful in that regard, in that it can tell us, again, what's happening from the heart standpoint. So four potential, or not four, four practical applications where we can use this molecular assay. The first one is in patients that are clinical. So I need an answer right now. These are patients that come into me that are dyspneic. They're in my either my emergency room or they're in your practice. They've walked in and it's 4:45 and it's the end of the day. And you need to know right now, is that patient dyspneic because it has cardiac disease, heart failure probably, or is it a respiratory patient? Does it have asthma if it's a cat, or is it some form of chronic bronchial disease if it's a dog? It would be very nice to know that immediately, within minutes. Again, you don't have time to send a test out and wait till the next day or so till the result comes in. Many of these patients, you would say, well, maybe I could just take them to X-ray. Again, we've already said X-rays are not always as sensitive an indicator or specific as an indicator of heart versus respiratory disease, and they're stressful. It's much easier when you're putting in an IV catheter in a patient who's more critical to save a little couple drops of blood in a red top tube and be able to go ahead and either do serum or plasma testing bedside. So that's going to be one, is differentiating cardiac versus respiratory. The second thing we can consider is in patients that are more stable. And in fact, these are subclinical, meaning that an owner doesn't even realize that a patient has heart disease, and we as clinicians may not as well. These are subclinical patients that are developing heart disease. And again, there's a number of situations where we have at-risk breeds in both dogs and cats. We might have patients that seem fragile for anesthesia. We're a little worried about what their heart's doing. We'll talk about certain diet implications that might cause us to want to screen for heart disease. But wouldn't it be nice if we could take a patient who is not exhibiting any symptoms, subclinical, and by virtue of their breed or other worries, determine whether they have early heart disease or not, and whether that should prompt us to want to do different things. Third application would be to say, hey, I already know you have heart disease. But what stage is it? How far along is it? And how severe is it? What is the likelihood you're going to go into heart failure? If you're in heart failure already, what's the likelihood that you're going to respond to medications? Again, that's the fourth application, is how efficacious do I expect heart disease or heart treatment to be? And can I use this hormone as a monitor for how efficacious my actual drug therapies are? Again, the patient might look a little bit better to me. They're breathing better, their heart rate's down. The owner tells me they're more active, but could I be fine tuning their drug therapies to do better things? Again, maybe BNPs can provide us that information that clinical signs don't, and allow us to make more of a appropriate drug adjustments and things that would, again, hopefully benefit that patient long term. Now, one real important thing to know about application number two, if we're screening patients for heart disease that don't show any signs yet, for example, here's a bully group of Great Danes. Look at those little monsters. They look like they're ready to attack the person holding that camera. What you have to know, though, is, again, BNP is only a point in time diagnosis or assay. It tells you what the heart's doing right this minute. It cannot predict what the heart's going to do in the future. So if you ever had a breeder say to you, hey, great, I'd like to run that BNP in my 6 Doberman puppies I have here today, this is not going to be a test that would be valuable in that scenario, because those puppies are not going to develop heart disease, if they do, until they're adults. So again, this is not something that can predict the future. It only tells you about what's happening currently. So let's look at the first application, the one I think is really important that would make me want to put this, I've already have, into my clinic so that we can get results within 15 minutes or so. You get plenty of dogs that come in, guys, that are labored breathing. Many of them are coughing. They may or may not have a murmur. They have fairly loud bronchointerstitial lung sounds, maybe crackles and wheezes. Some of them are brachiocephalic dogs that come in, and again, they have loud inspiratory stridors and associated respiratory distress. And you look at these dogs, they need oxygen immediately. They're emergencies. And in your mind, you're running through rule outs. Does this dog have, tracheal collapse? Does this dog have bronchial disease? Is this a brachiocephalic dog that has severe BOAS? Or is this dog in congestive heart failure? We know that Yorkies, we certainly know that bulldogs and pugs can get heart failure as well. Could this dog have pulmonary hypertension? We know that chronic respiratory disease patients, chronic heart patients can develop pulmonary hypertension. Again, most of us would say, well, let's go to the x-ray table. And we oftentimes get x-rays like this in this Yorkie, where that heart might look a little bit big to me. I mean, maybe it's all my nurse could get me with the dog tolerated was a lateral film. I don't have anything else. I mean, could there be a pleural fissure line? Is there pleural effusion, or is that just fat? Is there increased density and early interstitial edema here? Or is that bronchial changes? I mean, I just can't tell. And that is the insensitivity of running chest x-rays oftentimes in cardiopulmonary medicine. You take a look at that poor pug who's oxygen dependent, and you look at his x-ray again, the heart really doesn't look that big, but there's an interstitial pattern in the perihilar region, maybe even alveolar, it looks like to me. I get a VD luckily in this dog. Yeah, I think there's an alveolar pattern, but his heart doesn't look all that large. I mean, is that a heart failure patient? Is that a non-cardiac edema patient? Is it simply a BOAS patient? Again, difficult to tell just from x-rays. We need some other information. And naturally, we'd love to echo these dogs, do cardiac focused ultrasound. Not all of us have that capability. And again, it's more of a stressful diagnosis or diagnostic. So it'd be nice to take a blood sample and maybe be able to tell the difference. So there's a number of papers out. I just quoted 3 of them here for you on the side. But since, again, 2009, we've known that we can run NT-proBNP bedside in these clinical patients to help us determine whether their clinical signs, their dyspnea, if you will, their hypoxemia is due to cardiac versus respiratory disease, because obviously it's going to influence how I, as a practitioner, am going to treat that patient, whether I think it's congestive heart failure or respiratory disease. So if you look at here, we know that dogs that are normal, that have no cardiac pulmonary disease, and dogs that have mitral valve disease but are still subclinical and asymptomatic in stage B1, meaning that their heart hasn't changed, there's just a little leakage on their valve. We know that those patients generally run NT-proBNP levels below 700 normally. Maybe if your mitral valve's affected, you can go up to 900 picomoles per liter. So again, anybody who's less than 900, really less than 700 for sure, is going to make me think that any signs they have are respiratory in origin. Because again, these values are not high enough to be associated with heart failure. We know down here at the bottom, you see the congestive heart failure median. Most dogs in congestive heart failure are well above 2,500 picomoles per liter. Again, there are some variations in these numbers. There are always going to be some that are lower than you think. But again, there's generally a pretty clear-cut distinction between respiratory dogs up here who say, hey, it's my lungs, or heart failure dogs. Oops, I went one too far there on you guys. Or heart failure dogs that are down here and have these high BNPs up again, 2,500 or greater. Pulmonary hypertension patients tend to sit somewhere in the middle. As you can see in the median values, somewhere around 1,200 in publications. Again, there's a bit of a crossover, but what it tells me is if I'm above 900 and I'm below 2,500, I'm probably not in heart failure, but maybe there is some cardiopulmonary disease, and hypertension certainly piques my interest, and that's a dog that should have an echocardiogram done. So again, these guys, less than 900, are going to be treated with oxygen and respiratory drugs. Dogs that are 2,500 or above are going to be treated with oxygen, sedation, furosemide. Again, hopefully knowing that they have pulmonary edema. So I hope you can see the application for that. It allows you as a clinician to hopefully very quickly stratify what diseases you think you're dealing with and get on to what is going to be hopefully life-saving therapy for them. How about cats? I mean, look at this kitty cat here. You can see his tongue moving. You can see his chest, kind of a short, shallow, restricted breathing pattern. I mean, he obviously is dyspneic. Look at the ears back. I don't know that I want to strap him down to an x-ray table or hold him down on an echocardiogram table. Again, I'm going to have a nurse put an IV catheter in, and while they're doing that, if they can grab just a little bit of blood, so I can do either a plasma or a serum pro-BNP. In cats, again, to come in, is he in heart failure? Does he have pleural effusion? Is he an asthmatic? Could he be a cat with heartworm disease that had some worms die and he's now in that, hard heartworm-associated respiratory acute crisis? Again, an easy way to hopefully tell the difference. There's multiple papers that have been written again. They go back over a decade now that will, again, tell us clearly that looking at NT-proBNP can help us here. Cats that are normal or that have non-cardiac reasons for dyspnea are going to test with a low BNP, generally under 50, but at least under 100 picomoles per liter. Cats don't make as much BNP. Their ventricular, size is smaller. So from a number standpoint, their numbers are always going to be smaller compared to dogs. Cats that are in congestive heart failure tend to be at least, 300, if not 500 picomoles per liter or beyond. And again, it's a nice way to say, hey, if my BNP is low, less than 100, pretty certain this is a respiratory patient, and I'm going to treat them as such. If my BNP comes back in this kitty cat and it's 300, 500, 1,000 or above, I'm pretty certain that's a case with heart disease. And again, certainly furosemide and maybe thoracocentesis, depending on the circumstances, are going to be the focus of where I'm heading for treatment. So again, pretty cool applications, guys, as to how you can use the quantitative numbers looking at BNP, NT-proBNP, to tell you, is it heart, is it lung, with some degree of certainty. There's always going to be cases that are in the middle that you're not certain on, and that's again where it's valuable to still look at x-rays. It's very valuable to look at focused cardiac ultrasound exams because that'll help clear those things up. But in many cases, if we can get an idea first, we can at least be into treatment and helping these patients do better while we perform other tests. So let's look at the second indication for NT-proBNP. And that would be, can you use it for patients that you know might have heart disease or you think are at risk for heart disease in identifying and maybe going ahead and staging them? So for canine mitral valve disease, proBNP is not as important for identifying patients with it, right? Look at this dog here. He's coming to you today with a stethoscope in his mouth and he's saying, hey, guess what? I have a murmur. I mean, a murmur is the way that we identify dogs with mitral valve disease. We really don't necessarily need ancillary tests. Our physical exam is pretty definitive for most smaller breed dogs that have a systolic murmur over their left apical mitral valve region. I mean, you should go to Las Vegas and bet money that it's more than likely that they will be mitral valve disease. So I don't necessarily need a test to tell me, the stethoscope tells me there. But that's in contrast to, what about these dogs that get cardiomyopathies? And what about cats that almost exclusively get cardiomyopathies? They oftentimes have very silent heart disease in the earlier stages and moderate involvement to the point where many of them, the first day you know they have heart disease is the day they die. They become clinical and either drop dead suddenly or they come in with fulminant heart failure and we're unable to get them out of it. So it would be nice to take patients like this that oftentimes have no murmur or intermittent murmurs. It might be nice to take patients, again, who don't have any significant X-ray changes, ECG changes. Many times are normal in these sort of patients. I know that statistically, 3 out of those 7 cats are going to have heart murmurs. Well, which ones of them have heart disease? Because I also know that a heart murmur doesn't mean you have heart disease, and an absence of a heart murmur doesn't exclude heart disease. So we need a test in these cardiomyopathy type patients that would help us define who actually might have early subclinical involvement. And again, could NT-proBNP be that test for those patients? Boy, it can. There's lots of papers out there. These are papers from the US that are multi-institutional. We've got studies from Europe and other countries that look both in dogs that are cardiomyopathy breeds and in all breeds of cats, showing us that, again, running a plasma NT-proBNP level can reliably discriminate normal patients from ones that have heart disease. So again, if you don't have an echocardiogram, we're not going to turn it on for every patient that comes into your clinic. This is certainly something that you could screen for heart disease development. Who would you screen? Well, to me, I would screen at breed or at risk breeds. I mean, I know we're not supposed to profile. People tell us all the time, don't profile other people, but we're doctors. We're allowed to profile our patients, and we can look at certain breeds and say, I know statistically that that breed is one that develops heart disease as they become adults. And I want to know because I know that listening to their chest and taking an X-ray or an ECG may or may not give me any valuable information. So in dogs, you can see the list right here of dogs that are prone to getting dilated cardiomyopathies. I mean, we all know Dobermans, obviously, Great Danes, Irish Wolfhounds, but look, there's a lot of other ones, standard Schnauzers, Old English Sheepdogs, English Bulldogs, Dalmatians, Cockers, and Boxers. In cat world, we know that certainly Maine Coons, Ragdolls, and Sphinx are breeds that are at risk for hypertrophic cardiomyopathies. But there are others, Bengals, Burmans, British long and short hairs, Norwegian forest cats, and Persians. So again, if I'm seeing a patient today and it's looking to be a healthy adult in one of these breeds, I certainly might have the conversation with an owner. Hey, it wouldn't be wrong as part of our screening today in your dog or cat to run up NT-proBNP. It might allow us to determine whether your at-risk breed has heart disease before they start to end up, in more severe shape and come in congestive heart failure. In fact, because of the difficulty in cats, right here, cats with murmurs, I think all cats with murmurs should have an NT-proBNP done. Matter of fact, if I had my way, all cats in the world would get screened every year as part of their chemistry panels for this test. But again, the bottom line is that not all cats with murmurs have heart disease, but a proportion of them do. And certainly, if we come in and we hear a murmur in a cat, it would be nice to know through a simple screening test whether that cat has a heart disease that's developing behind the scenes. Occasionally, we get cases that seem like fragile anesthetics at CSU. It's not uncommon for the dentistry department to come down to us in internal medicine or cardiology and say, I got a cat that I don't hear a murmur, but he just seems fragile. He's older. I've got to do anesthesia today. It's going to be under for a while for some teeth getting extracted. I'm going to give him intravenous fluid therapy. I'm a little worried about whether he could potentially have, develop heart failure. A BNP would be a nice pre-anesthetic screen to say, hey, if it's a significantly elevated value, then yeah, there may be more concern. Maybe we should take a closer look at that patient before anesthesia is performed. And then the last one, which is relevant, in the last number of years, is patients, dogs or cats, that are taking these boutique, exotic, or grain-free diets. There certainly are concerned that there's some association with some of these diets in the development of dilated cardiomyopathy, systolic dysfunction to the heart, and that's oftentimes in breeds that are not listed here for dogs. In those situations, if you're on a beg diet, you certainly don't want to find out that you have developed heart disease when you fail. It would be nice, number one, to get off that diet if you don't need to be on it. First is my personal opinion. But secondly, if you're on that diet, I think an owner should be told, hey, you might want to do no, not told you might, you should do a screen to see if your patient's developing heart disease. And not all of us are going to be able to do an echocardiogram, but we can all do an NT-proBNP. So again, just some of the applications on where we might use it. So what would we be looking for? So here's canines. If we looked at dogs, again, we look at the certain breeds. We look at dogs that maybe are on a beg diet. Again, maybe a dog who seems a little fragile. Maybe they do, in fact, have mitral valve disease, and I'm going to anesthetize them. I want more information about their heart. If I run an NT-proBNP and it's less than 900 in a dog, for most breeds, I'll give you the exceptions in a second. Less than 900 suggests that that NT-proBNP level is not compatible with any significant change to the heart. And clinically significant heart disease would be unlikely at that time. So even if that dog had a murmur and had mitral valve disease, I'd feel comfortable putting him under anesthesia, doing his dentistry. If that was a Great Dane that was coming to my clinic at 5 years of age, and I ran this and I saw it was less than 900, I'd feel comfortable telling the owner, hey, at this point in time, we don't see any significant changes that would make us think your dog's going to develop heart disease anytime soon. Again, it might be a nice thing to do annual screening in those type of patients. If that NT-proBNP here in red is over 900, then it makes you as a clinician concerned that that patient, that dog, certainly has a higher likelihood of having significant heart disease. And that is something that we should certainly be pursuing. So these are the patients that we want more cardiac information. They should have a chest x-ray. They really should have an echocardiogram. It doesn't have to be a full echo as long as it's a cardiac focused echocardiogram or focused cardiac ultrasound, we call them FCUs, just to see whether there is significant disease that is developing and then in warrant of putting them on therapy. Now, who are the exceptions to the rules in between this 900 rule? Doberman pinschers have been shown that they can develop significant heart changes with lower BNP values. So we sort of use 735 in the literature as the cutoff. I just use 700 to be honest with you. If you're a Doberman who's got an NT-proBNP above 700, I'm going to press an owner for further testing so we can determine if there is early dilated cardiomyopathy and we can get that dog on therapy. The other breeds are Labradors and Newfoundlands. So we put them in yellow here, so a caution value, if you will. And we can put Greyhounds on this list as well. It's been added to it. For whatever reason, there is some variation in BNP levels based on different breeds. And Labradors, Newfies, and Greyhounds have been shown that even in normal circumstances, perfectly normal hearts, they can have BNPs that exceed that 900 picomole level. So if you get a screening test done in these specific breeds and it's above 900, I would still pursue testing to see if there is any evidence of heart disease developing. But if you didn't find any, you shouldn't be surprised because these breeds have more variation. Okay, those are dogs. What about cats? These 7 cats sitting up here. What do I do with them? Well, if I want to screen them, because some of them have murmurs, some of them don't, but if I ran blood work on all 700 of them and did an NT-proBNP, the ones that came back with a value less than 100, and actually we'd love to see the value less than 50. 50 really tells us there's nothing going on, but it would tell us there's no increased stress or stress on their myocardium. They're not producing BNP. Clinically significant heart disease unlikely in those cases, and we wouldn't pursue any further testing, even if they had a murmur. In patients that had a NT-proBNP above 100 picomoles per liter, that's considered abnormal, and that's considered might have heart disease. So again, we would want to go ahead and pursue further testing. And in cats, really, again, that focused cardiac ultrasound or focused echo would be the thing to do because that's the most likely going to be the test that's going to pick up on whether they have heart disease or not. So again, I think you can clearly see that you've got two major reasons to think about doing BNPs in your clinic. One, to differentiate clinical dyspnea patients into heart disease versus uh, respiratory disease. And two, to start identifying patients that might have heart disease from normal patients. And that way you can make intelligence decisions on who gets further cardiac workups and who is not likely to have any cardiac disease and can simply be followed along. In these at-risk breeds, I would follow them yearly. They can become their yearly annual exam. And if you do see over time a sequential increase in BNP, then that could be very important in identifying them early. Of course, if they're on a big diet, let's get them off of those diets. All right, so third application for BNP. What about staging mitral valve disease? I said we don't use BNPs to tell you that you have mitral valve disease, but once you already know a patient has it, they're a small breed dog, they've got a prototypic murmur in the left apex, it's a systolic murmur, holosystolic murmur. It's a pretty good bet they have mitral valve disease. Could I use BNP to help stage that? Because they would have to be if they were subclinical in stage B. Remember, B is divided into B1, low risk, versus B2, high risk for developing heart failure. I'd like to know if I could stage those mitral valve dogs. Now, most of us are going to use, as you see here, again, either focused cardiac ultrasound to look at LA to AO ratios for that, or we'll use chest x-rays to look at VLAS measurements to help tell us B1 versus B2 and stratify risk. But what if you don't have that? Could a BNP help you? Or what if it just wasn't clear? You got borderline values and you want more information. Yeah, you could certainly do an NT-proBNP to help in subclinical staging for mitral valve disease. Again, there's multiple papers that discuss that. And what we've basically come up with right now is that NT-proBNP will increase, no surprise, with increasing mitral valve severity. So the more regurgitation, the more activation of the RAS system, the higher the BNP is going to start to climb. Dogs that don't have heart disease and dogs that have early mitral valve disease with virtually no volume changes, no big activation of the RAS system, we would call those low risk stage B1 dogs. Again, we already said they're going to have NT-proBNPs less than 900 picomoles per liter. It's patients that start getting up in this 900 and above, up to 1500 and above values that we would be concerned are getting into more advanced preclinical mitral valve disease and would likely benefit from therapy. You guys know the EPIC study where it tells us that these B2 at-risk dogs or higher risk dogs should receive pemobendin. In this situation, we're going to go ahead and say, hey, again, if that BNP is get above 900 and is approaching, up towards 1500, I think we can reliably, based on studies, say that's a B2 patient and would likely benefit from the introduction of therapy, meaning pemobendin. And some of the papers actually talk about for every 100 picomole increase that you get in that value, your risk for all-cause mortality and development of heart failure goes up substantially. So again, we'd like to catch these dogs prior to them failing with mitral valve, where we have the opportunity to start medical therapy, or if we're really lucky, we have the propriety to go ahead and consider surgical management and maybe significantly affecting or even curing those dogs. All right, so the last one, the fourth one, evaluating survival and responses to our heart failure therapy. We know a little bit less about this right now in dogs. They use it in people, though. And there are some papers, as you can see, these are the 5 papers that have been written that talk about, once you're in heart failure, if you knew what your initial NT-proBNP value was, it might be predictive of how well you're going to do in failure, how long you're going to survive. Once we have started you on treatment, depending on how far your NT-proBNP value comes down, that might be, again, predictive of your response to therapy and survival times. We know, again, that these papers can tell us both on actual relative values or absolute values versus relative percentages, depending on how far you can improve your NT-proBNP, there might be, again, some data that would tell us how long you might live. Now, a lot of this is still being worked out. There's a lot of crossover. I would say that most of us are not really following the letter of the law for this indication. But I think you can clearly see if you had a patient who is in failure and you had a pre-sample and you ran a post-therapy sample where you maybe you're 3 months into therapy, you're on quad therapy for mitral valve disease, and there's a substantial reduction in their NT-proBNP, that dog should be doing well. And I think an owner can be told, hey, we're where we want to be. So again, certainly as time goes on, we'll get more information and maybe refine the ability for us to predict what numbers will tell us outcomes and with some statistical accuracy. All right, guys, what about limitations of pro-BNPs? The NT-proBNP assay is not 100% accurate. No assay is. We know that as clinicians. The sensitivity is pretty good, about 90%. So what that says to us is if you have significant heart disease that causes your heart to be stretched or stressed, you're going to have a high likelihood that this BNP is going up in your bloodstream and we can assay it. There's not a lot of false negatives with that test if you truly have heart disease. So that's a good screening test. And that's why, again, we would advocate using it for that reason. Specificity is not as good, 50 to 80%, depending on studies, maybe even 45% in some of the cat studies. And again, what that tells us is there's a lot of false positives. So again, you may find, especially in cats, that they'll be over that 100 picomole per liter mark. But I'll tell you what, as a clinician, our job, at least in my viewpoint, my job is to find patients that have disease and help them. And I would rather find those 45 out of 100 cats that had heart disease than not run the test at all and find none of them. So again, I can certainly buy the fact that if I get a false positive and I echo a patient because of that, I do a focused cardiac ultrasound and it's normal, then I can certainly go back to an owner and say, hey, this is actually good news. This is a test that is not as specific as we like. And in your case, your cat's above the norm or your dog's above 900, but yet it has no evidence of disease. And so we should be thankful for that. And that's a good application for that test. So again, although sometimes in statistics we become literalists and we'll say, well, that's a bad test because the specificity is not high enough. Again, think about what it's telling you. You still are identifying patients that have disease. Again, limitations, we already mentioned labs and Newfies and Greyhounds. They might be above normal, meaning you might end up further screening some of those breeds. That's okay. If they don't have heart disease, it's a good day. Certain comorbidities, medical issues can influence BNP and cause it to rise. Obviously, things that affect the heart, right? Hypertension, hyperthyroidism, CKD, those are all certainly things we would see with regularity in older cats. Be aware that if they have those concurrent disorders, their BNP is going to be elevated. If you are able to go ahead and manage those successfully, your BNP should come down. So again, it's a nice use of showing that you have improved the status of the heart when you have these concurrent diseases that affect them. Also be aware that, this is a test that if you're substantially dehydrated, again, you're not going to be filtering. Your GFR is down temporarily and your BNP may go up. So be cautious of running it in patients that are dehydrated. Like any other test, guys, if you get an abnormal BNP, correlate it with the history, physical exam, other tests you've done. And in all cases, if it's elevated, you need an echocardiogram to basically tell whether a patient has disease or not. But don't get too worked up about the fact that there's not enough cardiologists in the world to echo everybody. In today's day of age, almost every clinic has an ultrasound machine in it. It may not have a beautiful cardiac package on it. There's no laws that say you as a doctor can't take that magic wand, that ultrasound probe, and go north of the diaphragm and look at the heart. There are very simple techniques, very simple measurements called focused cardiac ultrasound that I would refer you to that can allow you quickly to tell whether a patient has significant heart disease. So use that to your advantage. All right, in a few minutes that I have left then, I just want to talk about NT-proBNP from our sponsor standpoint today, Zomedica. They have a beautiful little machine called the TRUFORMA machine. It's, again, a bedside or in-clinic assay that you can do lots of different tests, BNP being one of those. As you can see, it's a small machine. It has a self-contained cartridge. It gets put into it where a plasma or serum sample is applied. And then this machine can tell us what our BNP or other hormone levels are. It does most routine hormones, thyroid, adrenal glands. It does GI panel work, cobalamins, folates, and PLIs. So it's got a lot of applications for not just pro-BNP in your clinic. You can do lots of things, and they're constantly adding more tests. Right now, the NT-proBNP test is for dogs from the Zomedica situation, but I have word that the feline test is going to be out soon. I don't have an actual release date that they've told me, but I know things are being prepared, and you will have this for cats very soon as well. So what's cool about this test that differentiates Zomedica is from an immunoassay. This is not a traditional immunoassay that relies on ELISA or radio immunoassays where you've either got to use chemiluminescence or optical light diffusions. It doesn't involve radioactivity, thank goodness, but it's something called bulk acoustic wave technology. And basically, that means things like hemolysis, lipemia don't interfere or interact with this type of testing. You're not going to get a lot of analytical interference. So what it is bulk acoustic wave is in everything now. It's in my cell phone. It's in the airplane I'll fly on in a couple of weeks. It's in my car. It's a relatively inexpensive technology that uses sound waves to actually be able to tell us and measure from an assay standpoint how much of a certain analyte is present. So it has something called a piezoelectric resonator plate that's inside these cartridges. So that's your thing you see here in green and blue. I'm sorry, in green and black. And that resonator plate is going to be made out of some type of a metal. And basically, if we put a charge, a current, electrical current across that metal, it's going to produce a frequency, a sound frequency. And we can measure what that frequency is when it's applied across this piezoelectric plate. If we impregnate that plate with antibodies, then we can capture, once blood is put into the system, plasma or serum, we can capture whatever our analyte of interest is. So in this case, it's NT-proBNP, this little starburst guy here. So again, we can go ahead and grab onto them and bind them to the resonator plate. We can then go ahead and wash this system and add in another enzyme with a binding protein on it, that when it binds to that complex, it's going to permanently bind this to the resonator plate. It cannot escape, and it can't be washed away. We wash any other things out of that system, and we then go ahead and again apply that same signal across the plate, and we're going to get, depending on how much of the analyte of interest we've bound, we're going to get a shift in that sound frequency. And mathematically, whatever that shift is can be quantified into telling you how much NT-proBNP or how much cortisol or how much ACTH endogenous or how much TSH is in that blood sample. So it's a really cool technology. It's self-contained. There's no reagents you have to use. You basically are plugging a cartridge into a machine, adding a blood sample. Time to result is usually within anywhere from 10 to 20 minutes, depending on the assay, and you've got your result. So pretty neat thing to have, I think, in your clinic. How good is this? There's some white papers that have been put out by Zomedica, and I'm sure, although I'm not privy to this information yet, all of Zomedica's tests get independently validated by outside universities. We've done some at Colorado State. Mark Peterson's done some on the endocrine platforms. I mean, they're using key opinion leaders that are state-of-the-art people. As far as this machine goes, or this assay goes for NT-proBNP, it's been compared in-house to the CardioPet ProBNP, which is IDEXX's result, the reference laboratory. And basically what they have found is so far in the in-house results, excellent correlation, whether you use plasma here or serum here. You're talking R values that are above 9.95. So excellent correlation to what would be considered the gold standard CardioPet ProBNP at IDEXX, the reference lab. Looking at bias plots and plots of agreement, same thing, little bias and very good agreement between the assays, whether you're using plasma or serum. So from that standpoint, I fully expect when independent validation comes out, I'm sure the numbers are going to look very good because every other assay that's been done so far has been independently verified and has done really, really well.